We are live, Mr. Chairman.
Great. All right. It is just about 1 o'clock on the 20th of November, 2020. I am Luke Klippinger, Chair of the House Judiciary Committee, and this is a hearing, our second hearing of the pandemic with the Secretary from the Department of Public Safety and Correctional Services. This is a virtual committee meeting, so I ask you for patience if we encounter any technological or streaming issues. Before we start, again, I remind committee members that the briefing is being streamed on the Maryland General Assembly's YouTube channel. Committee members, if they have a question, will type the word question in the chat. I will keep track of who would like to ask a question, and I will call on you to ask your question as the opportunity presents itself. Again, today we are going to receive updates regarding COVID-19's impact on our state's correctional facilities and programs. We welcome our guests who are here to speak about this issue, including Secretary Green from the Department of Public Safety and Correctional Services, Assistant Secretary Scruggs from DPSCS, Rachel Successe, the Chief of Staff from DPSCS, and Dr. Cliff Mitchell, the Director of the Environmental Health Bureau Prevention and Health Promotion Administration within the Maryland Department of Health. Their presentations will be followed by questions and answers from the committee. And keep in mind, we do hope to conclude this briefing by 3 o'clock. So nobody get any ideas to take us till 4 in the morning again, like in 2019. All right, so with that, Secretary Green, I believe you're here, ready to go? Let's unmute Secretary Green. We can't hear him though. We can get Secretary Green unmuted. There we go. Secretary, go right ahead.
Very good. Thank you. And good afternoon, Chairman Klippinger and members of the committee. Thank you for having us. For the record, my name is Robert Green, and I'm the Secretary of the Department of Public Safety and Correctional Services. With me virtually today is Assistant Secretary Programs, Treatment and Reentry, Carolyn Scruggs. Assistant Secretary Scruggs also serves as our designated COVID-19 coordinator for the department. Also joining us is Chief of Staff Rachel Successe, and we're pleased to have with us from the Department of Health, Dr. Cliff Mitchell, Director of the Environmental Health Bureau. Next slide, please. Whoever's controlling the slides. There we go. Thank you. Today, we're going to provide a brief update on the department's response to COVID-19, as well as give an overview of pretrial supervision and home detention. Both of these programs are pivotal in our response to the COVID-19 pandemic. Safety and security of the dedicated men and women who work for this department and those individuals under our supervision remain our absolute priority. Department remains extremely diligent and committed to the COVID-19 mitigation efforts. Our responses continue to evolve, and we closely partner with the Department of Health to stop and respond to the spread of COVID-19 within our correctional system. Next slide, please. A key element of our mitigation and prevention efforts has been the increased utilization of diversion programs. This slide demonstrates several types of diversion programs to include home detention and pretrial programs run by local jails, home detention and pretrial programs that the department oversees, and private home detention monitoring programs that operate as private businesses. As listed in that middle column, the department operates its own home detention program that supervises individuals within our system who are approved for placement prior to the expiration of their sentence. The department's home detention program and eligibility criteria is outlined in statute. Inmates and detainees are eligible for the state home detention program at no cost. The Division of Corrections has the authority to approve and/or deny placement on that program. Pretrial supervision is a function of local jails. Since the department is, as we know, responsible for the Baltimore City Jail, we also run a pretrial supervision program in Baltimore City. It's one of the oldest in the country, and currently has 2,325 participants on the program today. After conducting interviews and investigations, the pretrial release supervision program provides recommendations to the courts concerning the pretrial release of individuals charged with crimes in Baltimore City, again, at no cost to them. This program has been nationally recognized for its success and its low failure to appear rates, as well as rearrest rates while under supervision. There are also private home detention monitoring programs that, again, are private businesses licensed under the Business, Occupation, and Professions article that provide fee-based home detention monitoring services to individuals who have been court-ordered to private home detention monitoring. And finally, local jurisdictions have also been given statutory authority to establish home detention pretrial programs within their jurisdictions. Next slide, please. As you can see, demonstrated on the slide before you, our pretrial release supervision placements have increased by 65% since March of this year. Next slide, please. Our home detention placements within the department, utilizing expedited placement of incarcerated individuals within our system to home detention. As this chart shows, the placements there have increased by 160% compared to last year. Next slide, please. As I mentioned earlier, there are private home detention monitoring agencies that monitor individuals who have been court ordered to receive private home detention monitoring. Currently, there are 3 private home detention monitoring agencies licensed within the state. They have locations in Baltimore, Frederick, Howard, and Prince George's County, as well as the city. Fees range anywhere from $10 to $18 per day, which is a cost to cover the operation of the program and monitoring equipment. There are currently 785 individuals who have been court ordered to private home detention programs. Next slide, please. This slide primarily illustrates and it focuses on our continuous efforts on population density reduction across our department. From March 1st to November 1st of 2020, there have been 12,960 individuals who have either been deflected or released from DPSCS custody. And as we know, this assists in the mitigation of COVID-19 amongst our population while reducing density of population. 3,869 individuals have been released from booking to Baltimore City, in Baltimore City. 4,641 individuals were released from pretrial detention prior to sentencing. 860 individuals were transferred from facilities into the custody of the department's home detention unit, and 3,590 individuals were released from sentence custody as an element of mandatory release. Next slide, please. The department continues to implement additional precautions to ensure successful reentry and connection to community resources, while also limiting the spread of COVID-19. Prior to release, inmates are being screened utilizing a COVID-19 questionnaire that has been approved and is continually updated by our medical staff and adheres to the Center for Disease Control and Prevention recommendations. All inmates are provided with COVID-19 educational materials, directions to self-quarantine for a minimum of 14 days immediately upon release, and instructions to wear and keep the face mask provided by the department, which will assist them greatly in staying safe. Our dedicated social workers, which we cannot give enough credit to, continue to work diligently to assist inmates with developing individual home plans prior to release. And in fiscal year 2020, while under, I would say, very trying and unprecedented circumstances, approximately 95% of those individuals were released with a home plan. Next slide, please. Maryland has been at the forefront in terms of reducing its incarcerated population since 2015 and is further demonstrated that with the implementation of the Justice Reinvestment Act. Over the past year alone, the department's average daily population has declined 10 times more compared to the same period of time last year, as demonstrated between the blue line and the yellow line. The current population is over 18,000, and we would suspect the current COVID-19 pandemic and our continued response may further impact those population numbers. Next slide, please. In terms of testing, the department continues to significantly expand and utilize COVID-19 testing capacity and protocols since we last spoke. The department first conducted tests of symptomatic inmates according to the CDC and the Maryland Department of Health guidelines. In accordance with the governor's announcement on May 20th, the guidance issued by the CDC, we shifted in a testing methodology towards wide-scale, targeted, and asymptomatic testing. Currently, the department is testing its facility staff on a monthly basis, with the exception of the Baltimore Central Booking and Intake Center staff, who are being tested on a weekly basis, as this is a significant point of entry into our system. The department also conducts serial testing of the incarcerated population on a weekly basis and upon intake into our system as well. The department's inmate medical contractors have implemented targeted serial testing since August 31st of 2020. And since that date, we've conducted 15,745 tests across the general population, as well as the chronic care subpopulations who we've identified and more closely monitor. I would tell you this total is dated. It literally changes hour to hour. We're in the 12th week of this serial testing of the inmate population, and are testing on average approximately 1,247 weekly, and that includes outbreak testing as well as all of the testing we do prior to transportation to courts. Next slide, please. This slide will illustrate for you both the progression of our testing expansion as well as the total number of COVID-19 tests administered. To put a very fine point on where we are, as of November 17th, the department has administered over 66,305 tests. And again, I would note to you, this figure is already dated as it continually changes. Next slide, please. This slide will show the positivity rate of COVID-19 in the department's testing during the first week of November in comparison with Maryland's general population. The statewide weekly positivity rate for inmates is near the community rate. And as of Monday, November 16th, the department reported a total of 270 active COVID-19 cases. 75 of those active cases were among staff, and 195 active cases among the inmate population. Unfortunately, similar to the trends that we are seeing in the community as we speak, we anticipate that positivity rate will continue to grow among our inmate population. Later this afternoon, we'll be posting our updated COVID-19 figures to our webpage, and I would expect to see that number grow above 460. I would note to the committee, our dashboard is updated and published every Monday and Friday on our website and is available to you. Next slide, please. Thank you. According to the most recently released data of COVID-19 infection rates in the inmate population, Maryland currently is ranked 33rd in the nation for that COVID-19 cases among inmates, and 40th in the nation for cases per 10,000 inmates. It remains a critical journey for us that will continue well into the future. Next slide, please. Throughout the course of the pandemic, the department has been consistently following the advice and guidelines put in place by both the CDC and our Department of Health. We instituted a centralized supply chain to assure sustainability of inventory of PPE across our department, as well as the deployment and quite frankly, very, very close tracking of the burn rate of that just so important supply. The department has distributed an enormous amount of PPE to keep our staff and our inmate population safe, including over 466,000 bars of soap, over 90,000 face masks among the inmate population alone. While not shown in this chart, I also want to note that we've distributed over 40,000 face shields to staff throughout our facilities. This photo highlights a bit of what our staff wear in our facility on a daily basis, every day doing their work: mask, face shield, gloves, and in quarantine areas, also those gowns. To date, we have distributed over 4.5 million pieces of PPE. And again, with the state's continued collaboration, we have a stable and sustainable supply chain. Next slide, please. The department continues to fight the spread, and we hold daily leadership meetings to ensure proper protocols are in place and are to be followed. And we are evolving those protocols as the science and our professional colleagues direct us. We are very fortunate to have MDH and Dr. Mitchell on all of those calls in some capacity, and he actively works with the department on those protocols and policies. COVID-19 review teams. We have compliance review teams that work in the community along with our environmental safety officers, and they make sure that we are doing what we say we're doing in our facilities, and they've conducted over 109 multidisciplinary reviews to make sure, again, both staff and our policies are doing what they should be doing. And I would note we've had those in place since early on in the pandemic, beginning in April. As pictured as well, the department is utilizing and has conducted over 300 rounds of professional deep cleaning throughout the facilities. This is a contracted service. This is something we don't do ourselves. High touch areas, high push areas, impact areas, living areas, all of those opportunity to be deep cleaned on a regular basis. And we currently have a schedule reaching into January of next year at this time. We've identified zones in our correctional facilities for the purposes of cohorting the inmate population. And I would also note we're working in collaboration with the Department of Environment on a COVID-19 wastewater detection plan across several locations in our facilities. They've already been identified, and this program will further serve to allow us to be proactive in our mission and responsive to the detection of COVID-19 across our system. We have negative airflow housing throughout our facilities. Those are units that are absolutely dedicated to the quarantine and isolation bed space. We monitor utilization of this bed space daily, and I would tell you, if not hourly at times. Next slide, please, slide 16. We're also in the process of initiating and implementing a rapid testing pilot program at the Baltimore Central Booking and Intake Facility. This is going to be a program where every individual brought to us central booking for processing will be tested from one of the many police agencies we serve in the city in that central booking area. In addition, we're offering flu vaccination clinics to our staff and to the inmate population in a proactive manner. And to date, over 3,500 vaccines have already been administered to our inmate population. We started that very early in September. Maryland also was one of the first states in the nation to proactively deploy the concept of the hospital tents at its correctional facilities as a component of the Maryland Department of Health and the statewide surge plan. I would tell you these facilities have already provided hundreds of patient day relief to hospitals across the system, as well as our quarantine housing in DPSCS. We'll continue to provide this and expand as necessary. It's a community standard of convalescent care, but I would note these are not intensive care units. Next slide, please. And our last piece, I would be remiss if I didn't talk about the recruitment and hiring of the essential personnel in our system. And we have surpassed 2019 year-end hiring data. As of the end of October, the department had hired approximately 591 new employees, and 402 of which are correctional officers. I would tell you that number, again, it is a bit dated. I've confirmed an additional 39 new correctional officer hires in the month of November. We are pleased to bring on, and we expect the addition of another 30 new correctional officers in the month of December. I would tell the committee the department's response to this with no previous book written on how to do it has been absolutely extraordinary. But I must note, this is a people-driven success. The women and men of this department have been and continue to be absolutely extraordinary in what they are doing every day since March 5th. When we were implementation of the emergency order, March 12th, we shut down visitation and began to plan for this pandemic and move through it. And it would not occur absent an incredible collaboration amongst many agencies, but first and foremost, the men and women of this department who are working under tremendously trying circumstances to do something extraordinary every day. Thank you for allowing us to give you that brief presentation, and we are pleased to answer any questions that you may have.
Okay. There's several others with you, Mr. Secretary. I think we'll go ahead and we'll start with questions, and we'll let people jump in as we go along here. All right.
Certainly.
All right. Thank you very much, Mr. Secretary. Indeed. Thank you. The list right now, Delegates Crutchfield, Davis, Moon, Delegate Jazz Lewis, Delegate Williams, in that order. We will start with Delegate Crutchfield.
Good afternoon, Secretary Green, and thank you so much for providing this briefing to us. We really do appreciate it. I have a point of clarification that I'd like to ask, and then just a couple of questions. You mentioned or described testing as serial testing. What exactly do you mean? Is that really universal testing, or, just if you'll just explain that a little bit to me?
I think I see Dr. Mitchell on the phone, or I would defer to him. He is probably running 3 meetings at the same time. So when we did the universal testing, we did everyone at one point. We did point prevalence testing. We looked at the entire system and what was occurring in the entire system. Dr. Mitchell, would you like to pick up serial testing and how we are doing that?
Sure. I apologize because I have one other thing that happened while I was doing that. So thank you, members of the committee, Mr. Chair, delegate, for the question. So we've, as Secretary Green has said, we've been working very closely with the department since the very beginning of this process in early March. Early on, there were a lot of questions about testing, particularly when there was insufficient testing for everybody. And we recognized what a heavy lift it was in the entire state to get adequate testing. As you know, the governor has made a priority of improving our testing capacity. And with the advent of that increased capacity, the goal has been to provide the most protective testing across the system based on several principles. And I just want to sort of go through the logic of this. So with respect to inmates in particular, given that we could not test every single inmate every single week, it's not physically possible to do that for a number of reasons, and we don't have the testing capacity to do that. The goal was to provide protection to the population and also recognize the increased risk and vulnerability of certain people within the institution. So the way we designed the serial testing program was for the inmates to recognize that we wanted to test at least as many as we needed to do in order to make sure that spread was not taking place within each of the facilities. So when the point prevalence testing was done in the May-June time period, we had the whole period of that, the whole purpose of that was to understand how much COVID-19 was in the system at that time amongst inmates. And it was around system-wide. We averaged that out in order to calculate how many people we would need to test in DPSCS in order to be confident that there was not spread taking place in any given facility. So we recognize once it's inside, it's very difficult to make it go away completely, but we were really concerned about making sure that it was not spreading completely. So the way we did that was to look at the population of each facility, understanding what the prevalence was in May and June, and calculate the number of people we would need to test in order to make sure that there was no more than at any given week, a 3% increase in COVID in that population over the baseline, which was 4.3%. So the goal was to avoid outbreaks. That really was the purpose of the serial testing. And the way it was designed was by picking on average, it was probably around 60 to 70 people in each facility and testing them. And there's a slight wrinkle to that because we wanted to oversample to be sure that people with vulnerabilities, risk factors for more serious disease were included in that random sample. So we actually made sure that in the samples each week that are done, we ensure that there are at least sufficient number of people who have risk factors, of whom there are somewhere, depending upon how you look at the risk factors, several thousand across the entire system. And they have been identified and they are put into the mix so that we know in any given institution, if that institution, that facility includes people with risk factors, they are oversampled to be sure that in particular, there's not an outbreak happening in the 2 years where they are located. So I don't know if that answers your question completely, but that's the basis of the sampling strategy.
Okay, thank you, because it sounds like what you're using is the old statistical standards, so maybe standard deviation, et cetera, in order to get to your sampling. So let me ask you a little bit more, Secretary Green, based on the serial testing, when do you expect, or Dr. Mitchell, when do you expect to possibly test again at MCIW? Because I understand there has not been any testing there of that population in the last 2 to 3 months.
I'd be happy to go back and look at that data for you, Delegate Crutchfield, and get that to you. We've been testing across the system. I would tell you, some of our systems have experienced and facilities have experienced incredibly good rates of maintaining infection amongst our staff, while others and areas, as we know now, are surging a bit. I'd like to look at that more closely and get that to you. But I don't think that is completely accurate, but I want to be 100% positive, and I will get you that data. Okay. Serial testing does a couple of things for us as well. As Dr. Mitchell is the expert of the who, the how, but I think it's important to understand in our systems what we're trying to do. We're zoning populations in our system. We're looking at outbreak, but we're using serial testing to also help us identify how things are moving by shift, by building, by mitigation factor, by program. So an example would be if we would see a connection to a vendor that came in as we started up a program, and then we had an outbreak that helps us control our vector and then know where we need to go. All of that is being done, not just when we talk about the contact tracing of serial testing. We're doing the statewide piece. Our occupational health medical team, Dr. Jessica Dempsey, about 20 hours a day is reacting to that serial testing along with Horizon, along with our staff, and kind of directing where we need to go. And most look at what we're doing with outbreaks, if it would be around food service or something of that nature. And perhaps while we're working, Assistant Secretary Scruggs will be able to get that data for us as well.
And I know it's difficult to do social distancing, obviously, but I'm also hearing from some of the advocates that there are situations where tiers of women in MCIW have actually been brought together. And specifically, I understand that the women who have jobs have all been put on one tier, and that there's some overcrowding there, and therefore, obviously they're unable to do proper social distancing. Would you be able to also check in on that as well, Secretary Green? I really appreciate that, to let us know.
I will check in on that, Delegate, but I would tell you social distancing is an absolute issue in jails and prisons. And what you try to do to cohort populations as we start bringing together programs, we don't want to stay on lockdown forever. We have to provide programs and opportunities to people. And as you know, and I've told this committee, there have been times where certain parts of the state have had less programming than another, and we're moving. Cohorting of populations that we know we can keep together, keep separate, and keep safe. Absolutely, we are doing that. Is impact upon social distancing? Yes, Delegate. You're going to, it's difficult to achieve both all of the time. And I think we don't allow perfection to get in the way of good and safe. And then how we overlay. When we started up these programs, I would give you an example. We moved serial testing into some of these programs because we wanted to see how the vectors were establishing. To be able to do a program for just all of these multiple tiers, we wanted to bring our work population back together. And to do that safely, if they're coming from separate areas, cohorting is absolute key and best practice that we have been given by MDH with the structures that we have. And I would frankly, I would say in many cases, it's working very, very well. And when you detect COVID-19 or you detect spread, you respond.
Okay, thank you.
You're welcome. Thank you, Delegate, for all those questions.
All right, thank you. It's in the chat, the order, and I'm going to add after the Vice Chair, Delegate Cardin. With that, Delegate Deborah Davis.
Thank you. Thank you so much, Secretary Green. There are 1,000,002 questions that I have, but I'm going to let my colleagues ask some. I was struck by your explanation in your presentation that you expected positive COVID cases to grow as they are in the regular population. Now, you don't have a regular population. If you're testing as much as you say you're testing, if you're treating as much as you say you're treating, how do you explain that comment that you expect it to grow?
Certainly, and I'll allow Dr. Mitchell to talk about community spread, and we'll talk about exactly what we are doing to mitigate that and what the science tells us about community spread with individuals that are going home every day. Dr. Mitchell.
Just unmuting myself. Thank you, Delegate, and thank you, Secretary. Delegate Davis, the challenge we have is that when COVID is anywhere in the community, when it's everywhere in the community, it's very difficult to keep it out of any facility. We have seen, unfortunately, because people go in and out of the facility, i.e. staff, it's really impossible to be 100% protective of any group of people unless literally you lock them in a place where there's no interaction with the outside world. The challenge with this disease is that we know that there is a certain percentage of the population, which is a significant population, that experiences this disease without any symptoms. And if you acknowledge the fact that there's widespread disease out in the community, there's no way essentially to be 100% protective of people who are interacting with those people who are going inside and outside of the community. it's been a challenge for us, as you know, across the country and across the world, and here in Maryland, both with respect to nursing homes where our most vulnerable folks are, with congregate care settings of all types, including group homes, et cetera. We've seen outbreaks in basically every place we know where there are people. There is unfortunately a risk of this disease getting in. And once it does, you can't really eradicate it. It's just the laws of biology and of math that somebody who is positive, a certain percentage of those will interact with another person. And so that's the challenge of this disease.
And if I may, Delegate, by no means do we accept that. The bubble begins at the door with just basic screening and temperature checks and PPE coming through the door. But inside our facilities, and we zone and we respond. And again, I've had to answer to this committee, and I'm pleased to do so, that at times we have limited movement to almost zero. And we know that movement, and just as we're experiencing in the community and within that environment, is one of our biggest tools in helping to slow that virus. I hope we've answered your question, Delegate.
Well, it sounds as though you believe it's coming in from staff from the outside, because there's no visitation in the jail, correct?
No, we have not had visitation since March 5th, but it is an imperfect, we're testing our staff. And as Dr. Mitchell noted, again, I'll refer back to him, the science of what we're seeing. We would love to see it get into no environment, to include our hospitals or our nursing homes. And we are testing to try to avoid that.
Okay, thank you. My next question is, we all know that the governor has instituted an executive order to try to reduce the numbers in our facilities. I will note that 1,200 people have been identified, but I'd like to know how you intend to implement this.
We're going to implement I would note to you that the accuracy of that number. That executive order was signed 2 days ago, and we are going through now seeing the number of population that can first come into the pool within that 120 days from the time the executive order is signed. And we will implement it the same way we did in April, judiciously. We will review the individuals that are eligible, go through the criteria on the executive order, and move forward with release to include victim notification, as well as contact with local state's attorneys. So I think it's very early for us to tell you what those numbers will look like.
Yes, I'm not as concerned about the numbers, because they actually, as estimated, they're actually less than 7%. But and it doesn't apply to local jails, correct?
This is an executive order for our state facilities. That's correct, Delegate. So
it doesn't apply to local jails. I think that ought to be noted also among the community. It doesn't apply to local jails. I am interested in the actual plan, because the order in itself is broad. And can you share with us, once you have devised the actual plan, what that might be? Because it also deals with parole and probation. And we know that there has been a stalemate with parole cases. So to say that it's going to be handled judiciously assumes that we already have effective judicial handling of cases. So if you could share with us later, I would appreciate it, how you plan to handle that.
Certainly, Delegate. Thank you. We'll provide you with the phasing of the plan. Chief Successe.
Thank you, sir.
When do you think that's going to start?
I appreciate that question. So in terms of, as you know, the governor signed a mirrored executive order earlier this year that had the very similar provisions, only the time frame of which is the distinguishing factor. So we will absolutely handle it in the same fashion that it was handled previously, and that we are very quickly, expeditiously, and judiciously reviewing all of those individuals that meet the criteria of the executive order, which it is spelled out in the executive order, but I'm happy to reiterate that if needed. And then we will provide the appropriate notification to both the victims and the Office of the State's Attorneys as required by the executive order. Those notifications, which mirror the ones that went out under the previous executive order, have already been drafted and approved and will be going out shortly. And our case management and our social work team work very closely with our Commissioner of Correction, with the Maryland Parole Commission, and with the Division of Parole and Probation to ensure as smooth a transition as possible and practicable. So again, it'll be the exact same process as it occurred previously. And in terms, I am able to indicate again, under the stipulations of the parole or of the executive order, the Parole Commission is required to accelerate the parole for otherwise eligible inmates who are at least 60, have a good record of institutional adjustment, an approved home plan, and are not convicted of a crime of violence. So we are definitely familiar with all of the stipulations and requirements of the executive order. Again, it mirrors the one that was issued earlier this spring, and we are absolutely, again, expeditiously, judiciously, and methodically implementing that order, which was signed on the 17th.
I would tell you, Delegate, with a very fine point, it began the moment we received it, the process.
So can we get an estimated timeline when you may start, when you will have gone through that list that you've identified?
We have already started, Delegate, and we will go through that list step by step and begin to review those individuals for release and move them in that manner.
Do you expect that it might be done within 30 days? I'm just trying to get a framework.
I expect, I wouldn't put a time frame on it at this point, Delegate, and I would ask that you allow us to look at all of the processes involved so we can move on that. I would not want to give you a number that I absolutely do not know.
And Delegate, if I may add, just to maybe kind of help you here, to get into the weeds of things, what we have to do initially is we have to look at our database and look to see who is eligible to be released within the next 120 days. Once we look at that eligibility for 120 days, which is screened by our case management team, then our case managers will then start screening out those individuals that do not meet the criteria that are outlined in the executive order. We'll also look at individuals that we potentially figure are high profile or may need extensive medical attention that we have to get medical assistance for. So we'll start attaching those services to those individuals. There's a screening that goes on with the Commissioner of Corrections so that he can review them, as well as the recommendation from the state's attorney, whether or not they get released. And if there are victims involved, we take that victim impact statement into consideration as well when doing those screenings as to whether or not we release them. So it's very similar to processes that we do day to day. Nothing extraordinary other than it is expedited because their release may not be for 120 days. And we usually start doing what we call our release envelope 30 days out. It's just making us start at 120 days sooner. So these are not processes that are uncommon to public safety.
Thank you.
Thank you, Delegate Davis. We're going to go now to Delegate Moon.
Thank you, Mr. Chair, and thanks everyone. I just have a quick follow-up on your discussion about what's going on these days with pretrial supervision. In particular, you mentioned that a few counties are opting to use private companies for this, and that, just if I'm summarizing this correctly, you're estimating it's $10 to $12 a day. I'm guessing it's the defendant that's paying that. So if, could be a few $100 a month in private fees. Does that sound accurate?
And clarification, Delegate, that's private home detention, that's private electronic monitoring. And some counties may use pretrial with electronic monitoring, but I can't speak for each individual county. We do not charge for our home detention program in the state, nor do we charge for our pretrial release program.
Yeah, so what do you know what is typically happening when someone can't pay the fee if the county is trying to do it that way?
Again, Delegate, I would not want to speak for each individual county on that issue. I would have to allow that to them.
Okay, let me poke.
They do
around.
not, they don't fall under our or under my authority.
Got it. Thanks.
Okay, we're going to go to Delegate Jazz Lewis.
Thank you, Mr. Chair and Secretary. It's good to see you. I hope you all are well. Delegate Moon asked one of my questions, so I appreciate that. I will flag just for other localities listening. I don't know if they're doing, but I know Prince George's County is taking on the cost for the home monitoring for our locals. I don't know if every local jurisdiction is doing that. I'm glad to see the state is handling that, but I think that's a good practice for others to look at. My question is about the fact that we are releasing inmates, which I think is a good thing, and you and I have spoken about that. Caseloads for state employees with parole and probation, I'm sure is going up with having to monitor and manage these folks. My first question, just want to know what are we doing to help balance that for state employees? And then my second question, and I will be done, is to what degree for staff that can telework, are we allowing them telework, and are we giving them the appropriate materials to do so?
Happy to answer that question, Delegate, and thank you. Our case rates around the state, as we have recently presented, I believe, are a bit down around the state, but we can provide you with that exact number. We implemented teleworking everywhere that we can. Obviously, all of you in your experience understand we are a public safety agency and not everything can be telework. Amongst our Division of Parole and Probation, I note that we have a significant number of staff that are doing some level of telework. I personally looked at schedules prior to this hearing of the number that are teleworking. Some are coming in. There are certain high-risk categories and individuals that must be seen. That is face-to-face public safety work. We have rolled out the teleworking capability, telesupervision, computers. I believe all of our agents, when I got here, did not have iPhones. iPhones are critical for a lot of reasons to be able to communicate and make that connection. So we continue to do so. To say that we will be a system that will have all of our supervision in a telework capacity, that is difficult to do when we have missions of public safety, contact with people, the ability to test. So it will vary, but where we can, this department has been very responsive to teleworking, and we've rolled out, I believe, around 1,200 plus Surface Pro or mobile devices across the system internally and externally. And that's something for the future. So that's not a COVID, as we've learned now, just like all of us on this phone, what we can accomplish. While I would love to be in the presence of all of you, what we can accomplish with technology, we're learning. Pandemic forced us to move forward. We're reimagining all that we are doing. But I don't imagine that we will ever take human contact out of every equation of public safety. So hopefully that helps in that explanation, Delegate Lewis. I would tell you that I have met on a regular basis monthly with the union, myself, 8 individual meetings with them. I've met with the union representing and have willing to do so monthly in the city. Did so with the DPP representation. They choose to do a quarterly, but we are always open to hear from our staff and will continue to evaluate teleworking.
And
one follow-up.
Back off of my apologies, Delegate. I just wanted to add that we actually recently submitted a joint chairman's report to the budget committees on this very issue, because I think that your intuition is spot on, that you would think that with the increase in releases, one would think there'd be an increase in the workload for our parole and probation agents. And no doubt that they do incredible work, and certainly with the more difficult or higher risk caseloads those agents do absolutely extraordinary work. In this report, which I would be more than happy to share with you, when we last reported on this at the end of fiscal year 2020, the average caseload ratio for agent was 74 cases per agent, which is below the national average of 82. And we've been also fortunate, while the secretary reported on the number of new hires to include especially correctional officers. In fiscal year 2020, we did bring on 29 new parole and probation agents, and we do continue to monitor the number of home visits they make, the number of virtual interactions that are made between agents and clients. So we absolutely maintain a close pulse check on these figures.
Thank you for that. I'd love to see it. You actually was a great segue for the follow-up I had for the secretary, which was, I think we were all glad to see the hires that are coming. We know there's a big gap between where you all need to be fully staffed for correctional workers and support staff. I was wondering, I didn't see, maybe I missed it, like our retention rate, to the degree that these folks are coming in, are we keeping them? And I just want to know if you had any info.
That's a great and, again, insightful question, Delegate, and we are. We publish a hiring and retention report monthly and submit that, and we are. As you know, we put some incentives in place for our staff that are senior, and again, I think trying to work very diligently to our narrative, our message, and some of those things have been interrupted by the pandemic, but I'm pleased that not satisfied. And our staff remain a big part of that hiring effort. So we would be happy to share with you that report that has the exact retention rates, Delegate.
Thank you. Thank you, Chair.
If I may, Chairman, may I answer Delegate Crutchfield? Delegate Crutchfield, so we've tested 568 serial at MCIW since August 31st, and that last round was November 14th, Delegate. Thank you for that question.
Thank you, Mr. Secretary. Thank you, Delegate Lewis. Delegate Williams, then Cox, Shetty, Fisher, the Vice Chair, Cardin, McComas, and Bartlett.
Yes, thank you, Mr. Chair, and thank you so much, Secretary Green and your team for providing this briefing this afternoon. My question that I have, and I don't think it was addressed, I didn't see it in the PowerPoint or hear about, was regards to the meal distribution for the population. I know you spoke about that on previous briefings. I believe previously you had mentioned that you guys had implemented kind of a grab and go system to try to maintain the social distancing as much as possible. Just was wondering if you could also provide kind of an update as whether or not that's still taking place, and, kind of talk about how the meal distribution is going to try to also maintain social distancing as well.
Very good. I think entirely across our system right now, and I would have to check, we're at a grab and go posture with this last surge. So we've done it a couple of ways over the last 9 months. Initial response, as we talked about, grab and go, going and getting it, to everything to delivery in the facilities. So we're implementing now, we're not implementing. Each of these is an evolution at a different period of time based on what we're seeing. We understand that mealtime also is a time, to be able to congregate with people and have conversation like all of us would enjoy doing. But right now, the posture we're at is either grab and go, but I would say more right now as we weather what we're seeing to keep people safe. That is a meal delivery method, but we're capable of doing all of those processes, and even looking at how do we provide additional snack foods and things of that nature during these lockdown times.
Okay. I just have a follow-up question on that. I'm glad to hear that that system is still taking place. One of the complaints I heard, I guess, is just kind of about the quality of the meals with the grab and goes. And I guess my question or comment would just be to maybe just provide more healthier choices for the inmates, like more fresh fruits and vegetables. I know that from a storage perspective, those don't keep as readily as maybe others, but I think you also, especially kind of given the health situation that's going on, want to maintain our population is as healthy as possible, and therefore feeding them food that would keep them as healthy as possible, with more fresh fruits and vegetables. And also, I guess my question is second question. With the meals, are they predominantly hot meals, or are they just more kind of like cold meals? Is it a possibility of providing more hot meals, especially as we're getting into these winter months? Again, just trying to keep our population as healthy as possible.
I think, Delegate, we have registered dietitians that do all of our meal control across the system. And I will note to them your interest in vegetables and fruits. We'll look at those menus. But we have a standard that speaks to the number of hot meals in a day. And in a normal circumstance, we have to get one hot meal to people in a day, but we'd like to do that far more. So again, take that under advisement and your interest there. But what we are doing, I think that is one department I've really counted on to do some incredibly creative meal delivery there. And I'll take special note of that the next time I visit the facility. Thank you.
Thank you.
Thank you, Delegate Williams. We'll go now to Delegate Cox.
Thank you, Mr. Chairman and Secretary Green and members of the administration. Good to see you all today. My question has to do with lawyer access, and I have a follow-up with that. But in regard to local jail policies, I've had some feedback in certain counties that indicate that there's policy coming from the state regarding lawyer access, even when there's provability of no issues. You know, the temperature is fine and PPE and everything can be handled appropriately, but yet lawyers are not necessarily provided access to clients, and then they have to get on a waiting list to make calls. Do you have a policy that could help could be disseminated for lawyer access to clients, first of all? And then secondly, I guess the follow-up would be, do you have pretrial release policies for the local jails that can assist local counties in applying for or in utilizing the state's approach for the different home detention options?
Well, as this committee knows, I came from that local perspective. And along lawyer access, sir, as you know, I have no control over how each individual county and their physical plan would allow attorney access. I can tell you in our system, we try to distance it if we can. We're providing mobile devices, everything from an iPad, which we're using today, or handheld device, if that is suitable. And upon request, should an attorney demand that they and wish to be in direct contact, we will honor that while appropriately maintaining the safety of the inmate population. That's how we do it. Your second question around pretrial, pretrial many years ago was one of my great passions and continues to be. I would tell you our county, some of our counties in the state have incredible policies and procedures, and we would be more than happy to share anything that we have with any of our colleagues on our pretrial process. I would tell you Bob Weisenkopf, who runs the pretrial program, is just exceptional in how they do it, their data management, and we're even looking again how we re-image for the future. So we'd be happy to share that.
Thank you. And a quick follow-up, if I could, about the lawyer access. Do you have a policy that can be accessed by the counties?
Chief Successe, I believe we have a general policy, but I would tell you, Delegate, we're operating under special orders now with the policy that would apply pre-pandemic and in the middle of a pandemic is different. So we would have a special order more than likely that where we're at. And I would, Chief Successe, can we get that from DOC and pretrial and provide that?
We would be more than happy to. Delegate, is there a particular county that you're referring to that we can make this information available? I know all of our COVID-19 policies and procedures, the majority of which that are actually posted to our public website, and available and accessible and searchable there. But if there's a particular county that you would like to send me offline, or just let me know, I'll be more than happy to make that outreach and make our either our policy and or our procedure available to them.
Thank you very much, Chief. And what would be the website that you just mentioned?
Absolutely, it's our departmental website. And if you give me one moment, I can actually just shoot it right into the chat box if that's possible.
Thank you very much.
And I would just note to you, Delegate, if I may, Chairman, we've also done some extraordinary things with virtual court, which perhaps some on this call may be experiencing now, that has really assisted us in access to courts, helping to facilitate that, and really pleased with that process. Thank you. Thank you for indulging me, Chairman.
Well, Mr. Secretary, since you went there for a second, I was going to ask about that for 5 seconds at the risk of getting the wrath of literally my entire committee who are waiting to ask questions. Can you talk about the virtual court, what you're doing to connect people with courthouses across the state very briefly, and then I'll go to Delegate Shetty.
Certainly. So my experience with virtual courts began many years ago at my previous employ, and doing that through bond review process. We visioned an opportunity to expand what we were already doing in some places in the city to the entire state, which is what we did. In every one of our facilities, we've developed a court interface room and process where we can go into the circuit and or district court. I must say we work very closely. We have a monthly meeting with our department, with Chief Judge Morrissey and Chief Judge Ripken. They have been instrumental in doing that. And we've actually done thousands of virtual courts. As this group knows, we are not doing obviously jury trials and trials over that virtual platform. I am fully committed to continuing to expand those platforms during this pandemic. And I think, again, one of the sustainable lessons we have learned for the future is that we can continue to provide that service. So those meetings happen monthly, and I have also met with an incredible number of the judges in each individual county and how they use it, and we're seeking to make sure that they are comfortable with it as well.
And absolutely. And Mr. Chairman, in terms of, we also track those figures, the number of in-person versus virtual court appearances. And I can tell you that in the span of 3 months, I believe August, September, and October, between circuit court and district court, 1,457 virtual court appearances were able to be facilitated within our correctional facilities. And to the best of our knowledge, those are working very well. And we do have a very close relationship with the judges.
I would note that Mr. Chairman, Assistant Secretary Scruggs and Dr. Mitchell were also key in developing our protocol that when we do have to transport, how we are quarantining, testing prior to transport, trying to maintain that, and also upon return to limit those vectors of exposure. So I want to recognize both of those as just done exceptional work there.
That's obviously a very challenging issue for those of us who are in the courtroom every day, the people who are coming in and out of court from different places across the state. So that has been something that I've been paying attention to and very personally aware of, I guess, more than anything. Let me go to Delegate Shetty, and then Delegates Fisher, the Vice Chair, Cardin, McComas, Bartlett, and Conaway.
Thank you, Mr. Chairman. Thank you, Secretary Green and team, for joining us today. This is very informative. So we understand that the climate control adjustments haven't been made yet, and the temperature in some of the facilities are often really cold. I'm really concerned about this as we get into our colder winter months ahead. Do you know yet when the temperature adjustments will be made?
We're actively doing that now, Delegate. As you know, we had some warm days, cold days. And Mr. Gauthier, the Division Director of Maintenance. And again, I know I brag on people too much, but I just need to recognize some exceptional work. And there's another individual that does all of the maintenance for our facilities. He's in that transition now, along with the adjustment of temperatures in our tents, And we realize we have some challenges with some older equipment, some things that they've replaced. That is an active conversation, not only on our COVID-19 meetings, but also on our daily executive calls. And we will monitor that. I know we had a couple of areas that were a bit cool, and he reported those corrected yesterday. So thank you for bringing that to our attention, and we too have that concern.
Thank you so much. Just a very quick follow-up, if I may. I know it's always a tight balance between getting fresh air circulating in order to balance COVID while also maintaining, an appropriate temperature inside a closed facility. Are you guys also planning to have mechanical air circulation available? So improving your HEPA filters, having individual filters where needed, so that as you are transitioning to indoor heating, you're not, overwhelming your COVID numbers as a result?
Certainly. So one of the things that we look at when we quarantine individuals, and I won't get too technical, but we'll look at that zoning. Zoning occurs by air handling units and by space as well, not just by physical space. I'm looking at our engineering report for a cleaner airflow. Some information that we've already utilized in our academy classrooms. We're using different types of filters already in the system and filtering processes, and we'll continue to work with our colleagues at MDH. You have to look at when you install those filters. I'm learning about back pressure and things that I didn't mechanically know about before, but we're looking at all elements of our system to do that. And that has been a piece that our colleagues at MDH have helped us with. And I would also note, I have the ability to talk to 50 other people that sit in my chair across the country. And we're learning very good lessons, stealing ideas, successes and failures from others as well around that. So thank you for your interest there, Delegate, as well.
Thank you, Secretary. Thank you, Mr. Chairman.
Delegate Juanita Fisher.
Thank you, Mr. Chair. I appreciate it. It's so good to see all of my committee mates. It's been really nice. And thank you, Secretary Green, for being here today. I have a two-part question, and forgive me if maybe you touched on it in the presentation, but I didn't get a full sense of it. Was the status when it comes to chronic care and what's going on with our inmate population that is dealing with chronic diseases. I know that last time you mentioned it, but the last time we were together, it was mentioned, but it wasn't really given a sense on what's happening and what the number of chronic cases that you're dealing with currently today.
I don't have the chronic care numbers before me, but I would be happy to get those from Dr. Balcom. I can tell you in general, in some regions and facilities, depending on medical, up to 45% of a population could have what would be considered a chronic care condition or a chronic care clinic type of condition. I don't have those numbers in front of me. We monitor those multiple ways, not only the visits with the physicians, but also through prescription monitoring and making sure that occurs. We would be happy, and I know Chief Sessions is making note of that, to provide back to the committee those numbers.
That would be great. And then I also think I would be interested in seeing the types of chronic diseases, like what's most prevalent in our population, would also be extremely helpful. And then can I ask a second question, Mr. Chair? I'm not allowed. Okay.
No, go ahead.
Okay, cool. And then my other question was, and again, I apologize if you touched on the briefing and I didn't get a full sense. It's been a very hard time for just the world this last year. And I really am concerned about the mental health of our population and their access to, a counselor, someone to talk to, any resources with that, as well as, we're heading into Thanksgiving and Christmas, and obviously the contact with family is very limited as well. So if you could speak to things around mental health resources for our inmate population, and if you guys are setting up different types of protocols or access to contact with family, as the next 2 months are our holiday months.
Thank you, Delegate. You obviously have a very special interest here. You're absolutely right. And we've set up a number of telepsychiatry options for our population. But I think it also goes back to one of the points I made, that not everything in our business can be done from home. And, you know, areas of telework and where you need to speak to someone, while I can put together exactly what we have in front of us, making sure that there's a presence of people to do that. Very conscious of that. Again, telepsychiatry, telemedicine, but also making sure our staff are trained. And one of the investments we've made here for many years is the mental health first aid program. We just graduated some more staff from that. I think we did a virtual session of that during the pandemic. It is a concern. It's on the forefront all the time as we watch mental health deterioration. It is not immune to our facilities. Dr. Beneski, Linda Beneski, is the vice chair with Senator Hester on a behavioral health subcommittee that's being directed by the Lieutenant Governor. And we just had a great session on sequential intercept. I'm a big fan of sequential intercept model, especially intercept 0, prior to them ever getting into our systems. So we're looking at across our systems, making sure that we've got eyes on people. And again, I think you've very much noted and defined the human factor of our work. That's why we must be present. We must be doing our rounds and be connected. So we're doing all of those pieces, seek to do more. You know, we are obviously missing our colleagues from the community, our volunteers. Our community programs are a big piece of what we do when we go into these surges. I hope we can, you know, nullify, turn the curve on this. I wait for Dr. Mitchell to call me in the morning and say, we're done. And Rob, please do what you need to do. But I think all of you have seen how intricate that is, working into serving people. So all of that creates challenges. And we don't have solutions for every single one of them, but they're on our radar of what we need to be looking at, what we need to be looking for.
And if I may, I think that the secretary is being a little modest here because he moderated that whole panel about sequential intercept model. And to your question, delegate, which is a really great question about mental health within the correctional facilities and chronic care. And Assistant Secretary Scruggs, correct me if I'm wrong, but I believe the last I checked, there were approximately 7,976 individuals that we had flagged as individuals with chronic care needs. That figure could be a bit higher, but that was the best of my knowledge the last time I looked. And Dr. Beneski, which Secretary Green mentioned earlier, who also participates on our daily COVID-19 leadership teams and keeps us abreast about individuals that need to be transferred over to our colleagues at the Department of Health for elevated care and treatment. And those transfers are continuing to occur despite the challenges, and we are testing prior to transfer to their facilities as well.
I think, and again, to Carolyn, I think one of our significant successes in a pandemic, I'm trying to find my glass being 3/4 full every day, I have to, is that we have created, through Carolyn and Dr. Mitchell and others, some lines of communication that didn't exist before, that I think are just on the ground lines of communication that are going to serve us well beyond this. Carolyn, in mental health.
I agree. And just so that you know, our staff have also been trained. We have within each facility, we have crisis de-escalation teams where they have actually received a week's worth of training through the National Institute of Corrections and been certified in crisis de-escalation because of individuals that may be experiencing some type of psychosis or mental instability at the time. Our psychiatrists, although many of them are teleworking, we do have a team that is still within the facilities for urgent and emergent needs because we have to have them on site because we need to mitigate risks associated with suicidal ideations and things of that nature. So we are still very strong within our facilities handling our mental health issues of our inmates as we move forward.
Okay. We're going to go to the vice chair.
Thank you. Thank you, Mr. Secretary, and for your team for being here today. It's good to see all my Judiciary Committee members here, especially those I haven't seen in a while. I have a quick question, kind of following up on Delegate Fisher's question. Mine specifically related to communication with the families. So it's my understanding that right now the department uses Skype to allow folks to communicate with their families. What happens if families don't have access to Skype? Are there other platforms that can be used, like Zoom or another platform?
So again, excellent question, and thank you for that, Delegate. As you know, when we shut down visitation March 5th, one of the first things I did was we implemented video visitation ourselves. Did it inside the department through our IT staff. We are not charging for that. There is no cost for that. That is a program that I intend to keep in place moving forward, if at all possible. I think it's been great. For me, being able to speak, again, spending time in the facilities and talk to our population, I've had great conversations with individuals that have not seen their family in many years. So to be able to do that, I would note that we began the 15-minute free phone calls. There are 5 of those a week for every individual. So across our system, we're not charging the population for contact with their families. I think that was innovative and creative. For me, where others may have started and ended, we have not ended that. You know, we need to keep our population connected to families. So both of those ways still exist, and they are at no charge to the families or the population, which again, I feel strongly about. I think as we continue to kind of revision and reimagine, and I don't want to overuse that word, I think people tend to, we're looking at absolutely everything we do to see what we've learned, how can we do it differently, and how can we refocus for the future. And to that end, I think we are on a Skype platform now. Our ITCD is looking at other platforms. Can't give you an answer of when and how, but we're looking at how we keep that moving forward and give people access. I think one of our great successes has been video visitation. I would tell you more than likely one of the next questions will be, when do we see families returning back? And I don't see that happening during the surge and these pandemic circumstances. I know some others have done so and have quite frankly had regrets, and we will be closely guided by Dr. Mitchell and MDH on that. So I hope that answers your question, and we're trying to find a way so that everybody has an opportunity. That's really important to me, that there's equity across our system of how we do that. I'm looking at things like community kiosks, but again, I think you can't rely on any one answer for anything. And especially around technology, if we can look at multiple answers that are going to be able to continue to expand the envelope to include more people, that's where we absolutely need to be.
Vice Chair? That's good? Okay. I'm going to Delegate Cardin, followed by McComas, Bartlett, Conaway. Then I've got some questions.
And my apologies, I didn't mean not to throw off the flow of things, but Vice Chair Atterbury, with regard to your question about utilization of Skype, we actually have on our webpage a how-to video visitation guide to walk families through, and we actually have a QR code that if you scan it with your phone, it'll automatically download Skype to that person's mobile device. So try to make it as simplistic as possible.
All right. Now we'll go to Delegate Cardin.
Thank you, Mr. Chairman, and thank you all very much for being part of this. I'm going to switch gears for just a second. I wanted to talk just a second about money. I'm looking at a letter that you received from Senator Gazzone and Senator McCray back in the end of July about your contract with Corizon. And it looks like there was some sort of an emergency. I'm reading the letter. There was some sort of an emergency decision, and Department of Public Works said that was not correct. I'm not exactly sure what happened, but it looks like there could be lots of money that we are foregoing or that we are losing because of a contract with a company that looks like it's not doing its job. The reason I bring this up, I wasn't going to bring it up, but I'm going to put you back on, is because you Assistant Secretary Scruggs and you, Mr. Secretary, both talked about, having to take people hospitalizations and utilization of serious medical facilities. And if Horizon is not doing its job, or they put us in a stronghold with a contract that we're spending millions of dollars a month on them, and they are not providing the services, and their profits are going way up because they're not sending people to the hospital. I think that there's some record keeping and some fiscal accountability that needs to happen. So I'm just wondering if you can respond to that.
Very good. So I believe the letter you're speaking of, sir, and I'll be brief, is directed at an emergency modification to a contract that took place for response for COVID-19 that the Board of Public Works returned to me for auditable invoice, and the negotiation of that emergency modification contract is still underway, and we have not paid the vendor any additional compensation and are continuing to negotiate that modification.
The letter did indicate about, I'm going to have to pull it up again real quickly, about monies on, hold on, expenses, additional funding, liquidated damages, and that apparently other states don't, one second, I'm going to bring you back because I can see you. Other states don't have these clauses, so we are providing a tremendous amount of money and having to get it reimbursed after the fact, as opposed to asking them to put up front the money and then ask us for reimbursement. I'm wondering if our contract is unique, and if Maryland is kind of getting a little screwed because of that.
We have a flat rate contract that was negotiated prior to my arriving. I believe that contract started in 2019. We follow the provisions of that contract. My specific response to you was around the emergency modification, which is what I understood part of that letter to be about. What we could do, Delegate, if you have specific questions, we'd be happy to give you a written response and give you an overview to those.
Thank you. And I'll just say that I think that as we go through and start dealing with serious budget issues, this could be an issue that you guys might want to be ready for.
We are, and thank you very much, Delegate, for those questions.
Because we're talking, when I saw that tens of millions of dollars, I'm just a little nervous that
healthcare is an expensive provision. Thank you.
And Delegate, we did respond to both Senator McCray and also Chairman Gazzoni. I'd be more than happy to share a copy of that response with you.
I have that response, and I'll look at it more closely as well. Thank you.
Perfect.
Thank you.
Delegate McComas.
I'm trying to, okay, good. Can you hear me? Okay.
Yes, Delegate.
Thank you, Mr. Chair. Thank you, Mr. Secretary. Thank you, Rachel, for being here. I have a quick question, and we've kind of circled around it, but maybe not hit the mark on it. With the fact that people can't visit in person to their in the correctional system, and that meals they can't socialize at dinner time, that everybody's kind of isolated. Are they doing okay? Has there been an increase in disciplinary problems, a loss of good time credits because there's been, fights? Has there been an increase of meltdowns psychologically for some of the prisoners? And then are they still allowed to go to school to get their school credits? Are they still allowed to have religious services inside? In other words, I kind of got the impression when you were initially talking, and I didn't hear the very, very beginning because I had a phone call, so I had to run out and take care of that. I'm just kind of curious as to how things it sounds like they've lost a lot of the socialization and the programs that help them feel like they're making progress. And also I want to ask you about the jobs. Are the folks still doing the beekeeping? Are they doing the laundry? Are they doing the printing or the printing, and also let's say the furniture making, the graphics and all that kind of stuff? Are they still kind of able to do some of these things that keeps them busy during the day so they don't look at the four walls? And are they getting exercise?
Delegate, you covered a great deal of ground, so I'm going to do my best around that. Thank you. And I think I can wrap some of them up in kind of a singular response. We're doing. There was a time when we brought our colleagues from DLL, or from Department of Labor back into the facilities. As you know, they run our education programs. We began them, and then you see a surge and you pull back. So that has been a bit like this. If I have a surge, we're going to pull back. We're going to do contact tracing around that and see what we can do to further isolate. Our schools just in person probably 2 weeks ago, I believe, Assistant Secretary Scruggs, we had to shut them down. What we're doing is we're doing as best we can, material handed out into to the inmate population. We are using remote where possible. I'm looking at some tablet technology along with Secretary Robinson in education. But again, they come and go in terms of what we're seeing with our viral spread. So for example, Maryland Correctional Enterprises, we had about 65–70% of the population back in work in some of our areas. And if you have an outbreak or you see a surge, I'm not going to, not include them in that slowdown or that step back. So we've had lots of programs operating. We've had lots of programs contract. So MCE right now, a meat plant is running and a couple of other programs. But when we hit this surge under advice from MDH, you can't pick and choose. And you've got to be able to pull back for the protection of all. I would tell you, this committee knows I'm a programs guy. I want the population to have lots of programming. Lots of programming means lots of movement. And when we have surges in a facility, that just can't happen. As soon as we have slowdown, we bring it back. So example, very productive program and one that's greatly loved in our system, vet dog program. Brought those programs back, suspended, went virtual, pulled back. Based on what we're seeing. We're going to roll those programs, and there's congregate programs in these communities, which what our prisons are, they're communities, and how we manage them. We're getting people outside. We're getting them outside in smaller numbers. We're investing in some of our larger facilities, such as RCI. By the end of this week, we will go from these one big recreation yards to 6 smaller, so we can put more groups in smaller numbers out and socially distance. We're looking at this opportunity to do all of that, but it is all driven, Delegate, by when we begin to see viral spread, contact tracing, and how that moves in our system. Assistant Secretary Scruggs, you want to add to that? Your programming is, I know, is near and dear to your heart.
I think, excuse me, I think you hit it right on point. We're using our virtual opportunities as much as possible for programming. For those individuals that are enrolled in GED classes, we do have virtual classrooms with Department of Labor, in which we social distance and limit the number of inmates that come into the classroom, and the teacher is actually on the screen. Our post-secondary education, many of them are already virtual. So Bowie and many of them, Goucher, they are doing virtual. We're taking the inmates into a classroom that's usually no more than 6 inmates at a time, where they can again social distance and still receive the education and training that they're using. We're doing the same thing within our occupational and training center with with them as far as our print shops and our auto mechanics and things of that nature, because that center sits aside from any of our facilities. And we continue to watch the outbreaks there. So we are programming them minimally, but as best we can, given the climate of the institutions based on whether there's an uptick or not.
Okay.
Just one quick question, if I may follow up. In other words, after they use either the recreational space or they use the classroom, is that sanitized for the next group that comes in?
Absolutely. It is cleaned after every encounter.
Thank you.
All right, we have Delegate Bartlett, then Delegate Conaway. Delegate Bartlett, Delegate Conaway is very excited that he's next. Delegate Bartlett.
I'll ask many questions. Thank you, Mr. Chair, and thank you, Mr. Secretary, Chief, and Assistant Secretary for being here. I want to first commend you for the video conferencing of the families. I'd also like to suggest that it continues after COVID, because and it may not be a free service, but I think it should continue after COVID. That has been part of the problem in the communities of color who cannot travel to see their family members who may be far away. The other thing is, I was looking at the, I was looking online, Chief, I was looking online and at the website, and I saw a document, but I didn't see an update to that document, and that's with respect to inmate health pregnancy management. Is there an update to the 2016 inmate health pregnancy management?
Thank you, Delegate, for that question. I would be more than happy to take a look at that and get back to you on that, but I do not know off the top of my head.
Okay, well, the reason why I was looking there, because I wanted to see if I could get the answer to my next question. Are inmates still tested or given pregnancy tests upon entry into the population? Is that part of protocol? Okay, and with respect to women's health, are hysterectomies performed as at any of the facilities, meaning MCIW?
I would, if I could, Delegate, I'd like to get that information for you. I cannot answer that.
Okay, and then my last question is with respect to women's health. If you could also just answer the question, so about Pap smears, if they are done on a regular basis, do you all and are they performed at all? And what other means with respect to women's health what other testing is given and procedures, medical procedures are given with respect to women's health?
Very good, Delegate. We'll get all of those answers for you and have that data for you.
Great, thank you.
Delegate Frank Conaway.
Oh, wait,
Thank you, Mr. Chairman.
I'm sorry, I forgot. There was one more, really quickly.
You said you had lots of questions, and then I thought you were done. And then let me go to Conaway. I'll come right back to you.
Okay.
Thank you, Mr. Chairman. So, Dr. Mitchell, you spoke about a baseline of 4.3% for the inmates for September, I believe, with a 1-week growth rate of about 3%. So does that mean at the end of week 1, the infection rate would be about 7.3%? At the end of week 2, the infection rate would be about 10.3%, which would also mean that at the end of October, you would have an additional 12% infection rate, bringing that to 16.3%. Second question, Secretary Green, are you saying that there's a problem or potential problem with the wastewater purification, and do we know if the COVID virus can contaminate water, and can it be transferred through the public piping system? Thank you.
Delegate, I think there's confusion. I'm going to give both of those to Dr.
I could actually answer
Mitchell.
those questions.
Before doing so, or perhaps after such, I had an issue trying to get off of mute, and I do have the response to Delegate Bartlett's question about the services for women. So happy to circle back with that.
All right, we'll get to that in a second. Let's go to Dr. Mitchell, and then we'll go from there.
Sure. Apologies, Delegate, because I was clearly not clear. So the strategy for serial testing is to prevent increases in transmission rather than to expect them. We do expect that there will be the possibility of transmission, but what we wanted to do was prevent outbreaks. So if you go back to May and June when we were doing, when DPSCS did universal testing of every single inmate in the system over about a 4-week period, we took that as basically where we were in May and June. And what we then said is we want to test so that no matter what happens in every single facility, we will know if there is a 3% or more increase over that baseline. So the goal of the serial testing was to prevent outbreaks, not to assume that they're happening. So what we did was, and let me see if I can sort of take you through this. So we picked, in any given facility, we picked enough people statistically so that if the rate in that facility had gone from 4% to 7%, no matter which 60 people we picked, we would have seen that increase. Does that make sense? So
yeah, that's your sample groups. I took statistics and quantitative.
Right. So we were not expecting that there was going to be an increase. Rather, this was to make sure that if there was an increase, we would detect it and be able to respond accordingly.
What number did you come up with? With the new
roughly
test?
speaking, for most of the facilities, around 60 to 70 people.
Which was an increase by how much percentage?
So statistically,
1%.
Let me see if I can take you through this. So basically, if you have 4% of the population that is infected, we assume potentially infected.
Sure.
You take that entire population and pick at random 70 people.
Sure.
And test them. Now, you don't test, to make sure we understand this, you don't test the people who are already positive, because remember, people who are already positive, we do not retest for 3 months. So take people out of the pool who are known to be positive, test 60 of that remaining several hundred to, in some cases, more than 1,000. And if in that population of people who are known previously to be uninfected, you identify X number of people, you will know that the amount of spread in the population as a whole is at least 7%, which was basically the threshold.
Right.
Put another way, if we had detected at least 1 or 2 people in that following sample, we would know that there was at least a 7% spread in the population as a whole.
Right. And how many did you detect?
So that depends on the week and the facility.
The first week, at the end of the first week.
Oh, I can't tell you at the end of the first week, because I don't know that. We're going back to whenever we started the serial testing, which was
August.
Basically August. So we have detected people. And to be clear about what that means, the advice that was given is so that there are several nuances to this. If somebody becomes sick and it looks like there's an outbreak, that actually changes the testing frequency for that area, because what will happen is that there will be additional people tested who were close contacts in some cases, or if they become symptomatic. So this is the serial testing of asymptomatic people who are not having symptoms, to make sure that we're limiting spread. We knew that in some cases we were likely to have cases, and those cases are included in the sample, so we know that spread is happening. But in addition, we also look at people who are uninfected to make sure that it's not extending beyond the people who have manifested symptoms.
Sure. Okay. Thank you.
You're welcome. Oh, and now wastewater, which
you didn't give me any idea what you think the total number is right now. Which
of people who are infected in the overall population?
Yes.
Well, I think the best example of that is the percent positivity that the secretary displayed for you. I mean, it's not a perfect example, but we are looking at spread in the entire community. We know there's spread happening within the facilities, and we have cases. Department has cases in several of its facilities, including and those are available on the website. But we know there is spread taking place within some of those facilities.
Well, the reason I was asking is because if you're having over 7%, 8, 9, 10%, and according to what Assistant Secretary Scruggs said, if you're going to have 4 months before you have pre-release or release, early release, then the person would have a greater chance of being infected if they stay in, if the numbers are climbing. Therefore, we need to kind of balance that out to look for early release.
Yeah, I can appreciate that. I will point out, and this is not meant to be a comment on pre-release. It's simply meant to be a comment that everybody is at risk everywhere. And
Okay.
if people are released, they are also unfortunately going to be at risk in the community. And so that's simply a recognition.
Well, that's just based on you're saying that there's one number, but what I've been trying to get around to is the number of the infection rate in the inmates higher than for general population, for people who walk in.
So, right. No, I
That's all
understand.
I
I
was
can
trying to-
appreciate that. So, and again, I would think I go back to the slide that the secretary showed, which was the positivity rate in the community and the positivity rate in the DPSCS facilities as a whole. I think statistically, since that represents a sample, the true positivity rate in the entire population is probably, and I'm guessing now because I haven't done the numbers, but it's probably within the range of being the same, probably. But it's at this point that would be we'd have to do some fuzzy math to know
right
the answer to that. But at least at the moment, it's lower than the community spread overall.
Okay, can the COVID be transferred through the water, you think?
So wastewater is one of my favorite topics, for better or for worse. And who knew? And it turns out that yes, so let me just explain how that works. When somebody becomes infected with COVID, the virus replicates both in the GI tract and in the lungs. And so it can leave the intestinal cells, the epithelial cells, the intestinal cells, and go into the feces, and from there is excreted. And in fact, if you remember the original SARS in Hong Kong, the first pandemic, that was also an example of a virus that could be transmitted through fecal to inhaled aerosol transmission. In general, the virus, and there have been some studies of this, you can detect viral RNA pretty far down in the waste stream, which is the basis of this testing that's being done in wastewater across the country. However, being able to detect the viral RNA is not the same thing as being able to be infected by what's left in the wastewater at that point. What we do know is that the bacterial processes that are used to digest sewage in sewage treatment plants will almost certainly kill the virus. So treated sewage is not going to have live virus in it. However, we certainly do recommend not coming into contact with wastewater from humans for a whole bunch of reasons, not just COVID, but pretty much everything.
Now in my district, a lot of homes get flooded when the Jones Falls back up and that sewage comes in. Now, you're saying that sewage can release airborne?
No. Yeah, no, I just want to be clear about that. You can find it when you extract a large volume of sewage, sewage water, and then you do some analyses and you'll find it in the water or the sewage itself. But it doesn't aerosolize unless you actually aerosolize the water. So you would have to actually go down and aerosolize the water in order to generate that.
All right, thank you very much.
You're welcome.
And Delegate, if I misspoke, how we're going to use wastewater testing. So if we had an area, building A, that we believe is where we're keeping a very vulnerable population, and we believe that that's a clean area and we don't have any COVID there, we're going to put a device in the clean out of that housing unit that's going to sit there for, I believe, 24 to 48 hours, and it's going to take a sample and test that wastewater. When that wastewater is tested, the company's going to come back to us and say, whoa, wait a second, you do have some COVID there, and it's going to get us 4 to 5 days ahead of potentially our serial testing or transmission. So that's how we're going to use it as a system. So it's another one of those zoning measures for us. And my apologies if I wasn't clear on that, Delegate.
So would the COVID show up in the wastewater before it shows up by your temperature, by a person's temperature? Or?
That's actually one of the that's actually one of the most useful things about it. It's been used in colleges and other congregate settings, and it has actually been detectable before people manifested symptoms.
Thank you so very much.
You're quite welcome.
Thank you very much, Delegate Conaway. We're going to go to Rachel Successe to answer the question, one of Delegate Bartlett's questions that I'm going to let her finish up. And then I have some questions, and we're going to start to move with some deliberate speed here. Delegate, okay, so Rachel Successe now answering one of Delegate Bartlett's questions.
Thank you, Mr. Chairman. My apologies for my technological difficulties here. So I just wanted to confirm, and this was something that was presented before the General Assembly during the 2020 session, and I recalled it, but I had a hard time getting off of mute. So absolutely, we do have OBGYN services at the Maryland Correctional Institution for Women. They are on site at least twice weekly. And in terms about the question about the performance of hysterectomies, if clinically indicated, then those procedures do take place, but at off-site hospitals. And Pap smears are conducted annually.
Delegate Bartlett, go ahead and ask your next question.
Okay. My next question was actually completely off that topic, which is why I didn't make a quick enough shift. But it is with respect to video conferencing, I guess this is for Secretary Green. Is there video conferencing between public defenders and inmates currently? Is that something that is allowed, or is that something that's done or being set up?
We have video conferencing available in the pretrial environment in the city. We can put in place and have in place the ability for video conferencing out into our facilities for attorneys. And that video conferencing, again, a delegate, maybe iPad, maybe even using small mobile devices to give it directly to the individual, the inmate. We want to expand upon that for all of our external whether it be public defenders or individuals that provide services for the inmates. We have the capability to do that now, and we want to expand upon it. And again, video conferencing in a broad depth of other disciplines as well.
And Delegate, we actually have a meeting upcoming with Mr. Paul DeWolf, as well as I believe his head of information technology, which I'm very excited to meet. I think he has the coolest name. His name is Mark Six. And I know our head of our information technology division has had a number of conversations with him to ensure that we're meeting their needs as well.
Okay, great. Thank you. Thank you, Mr. Chairman.
Thank you. I have a few questions, and I'm going to try and get them in here, and still we'll see if we can get a few more second bite at the apple questions. At the beginning of the presentation, or close to the beginning of the presentation, I do want to thank you all very much, because I think this has been incredibly interesting and incredibly helpful presentation here today. There was a graph that showed that there were about 20,000 people on average that were being held in DPSCS facilities, and that was down to about 18,000 now. I guess my question is, if you broke out the Baltimore City Detention Center, what was the average number of people being detained in everywhere except the Baltimore City Detention Center in March? And then what's that number now?
I'm watching the Steam, Delegate, thank you for that question, run off of Rachel Successe's keyboard. I'm sure she's going to have that for us quickly. In general, I would say that's probably a reduction of anywhere between 1,800 and 2,000 people, but that is a guesstimate. She's going to, I'm sure, get for us the exact numbers.
I'll give her the opportunity to get those numbers. I guess my broader question is, it looks like there was a 10% drop in the average population there from 20 to 18,000. I guess my question is, if the my suspicion is that given that the number of people being arrested in Baltimore City has dramatically dropped since March, and it's not a judgment on whether there should be more people arrested or not. It's just the fact is there have been fewer people arrested. How many, that's fewer people going through that system. Is that what's driven that lower number overall, or not? So I'll give Ms. Successe the opportunity to get that.
And I would tell you in general, no, Delegate, that is not the sole driver. While you have less people, obviously there has been deflection opportunities where the state's attorney and others have chosen to deflect individuals out of the system to begin with. We've got deflection going on. We've got diversion through pretrial. You have a jump in pretrial from 825 in the beginning to 2,325. If we didn't have that program, you wouldn't have that opportunity for that level of diversion. So I would say that while statistically less individuals coming in perhaps lends to that, but I would not say that it is proportionately and statistically proportionate that is the reason in its entirety for that drop. The executive order, accelerated parole, all of those options go together. We could do a complete breakdown for you across that release, those release valves, but I would not credit it all solely to a smaller population.
Well, that's fine. I appreciate that. I guess my question is how many people were in Baltimore City. I think that number is somewhat indicative of, and if the percentage isn't, is close to 10% in BCDC and then okay, but it strikes me that I'm wondering whether that's where the big source of it is.
Rachel, if you can break it down, if not, we will give you the breakdown of the reduction of DOC population, reduction in pretrial population, and we can do that for you.
Absolutely. Unfortunately, that is not a statistic that I have at my fingertips at this moment in terms of a breakdown between the reduction in population specific for the DOC committed population versus that of the committed population for the Baltimore City Booking and Intake Center. But what I am able to say is that while in April, we absolutely saw an incredible dip in the number of bookings conducted at the Baltimore City Booking and Intake Center, as one may imagine, and as Chairman Clippinger, as you just indicated. However, more recently, we're seeing an absolute uptick in the number of bookings and arrests that occur at the Baltimore City Booking and Intake Center. And we monitor the space at the Baltimore City Booking and Intake Center. It is one of the only primary pre-trial buildings that we have at our discretion in Baltimore City. And there have been certainly days where it's been pretty tight, but we do monitor. We work very quickly and very collaboratively with our partners in the judiciary, the OPD, and the Baltimore City State's Attorney's Office. But yes, our bookings declined significantly back in April. However, right now we're seeing more of a normalization in terms of arrests and booking at the Baltimore City Booking and Intake Center.
I guess the other thing that and look, I'll look forward to the numbers. I'm not going to dwell on this too much longer, but I guess what I am seeing certainly and both anecdotally and objectively is that there are fewer people who are being detained by judges. And I'm genuinely not casting a judgment on that one way or the other. I just, that is, the state's attorney's office has said that they are prosecuting fewer people. The judges seem to be putting fewer people in jail because of COVID. So I'll be interested to see those numbers. Let me move to another couple things here and try and be deliberate. I had a comment come to me yesterday, and I mentioned before, I mean, I am reminded on a daily basis, I'm a state's attorney. Sometimes people have not nice things to say. Some people do, it's fine. The number of people who come into the courthouses is a big issue. It's a massive issue all the way across the state, and particularly in district courts. And so one of the questions that I have as PNP, as parole and probation runs underneath you, is some of the people who are ending up in court are people who are being brought back in on violations of probation. And in some cases, I'm understanding they're being brought in for violations of probations for failure to complete community service during a pandemic. So I guess my question, and it's not just solely on P&P, because obviously the judge has to sign off on these things too. But I'm wondering how much discretion, as P&P is doing the best job that they can in difficult circumstances, how much discretion are they being given to say, okay, we understand that you're not able to do community service during the middle of a pandemic. We understand that you're unemployed and you can't pay back the restitution. Normally I'm fighting for people trying to get restitution. Obviously, these are very difficult times. Compounding, these people then have to come to court. So it compounds a problem downstream. I'm wondering how much that is showing up on your radar screen at all right now.
So Delegate, I think, thank you very much for that question. And with DPP, we are not in that posture, and I will confirm that with Ms. Director Danner. I do believe what we're seeing is with the courts being slowed down, we're seeing a number of FTAs that were probably issued well before the pandemic began, and really, I think we've taken on a different posture of what we expect from people inside a pandemic. It's not to think. I know how we are looking in that and trying to be while very much taking that public safety obligation to heart, understanding what people are experiencing. I'm going to look at that number, and we can look at the absolute number of FTAs that have been issued during the pandemic. I would be quite shocked if those were high. I think a number were probably pre-pandemic, but I want to get those figures for you and look at what that downstream is. I think I'd also note to you, Delegate, under JRA, a different type of supervision, a different focus by our agents in terms of it is not a check the box kind of supervision anymore. It's very much holistically looking at the entire individual. And we've actually, through another process, done a great deal of I think, digging into how we're doing that and what we're doing there. So that FTA question interests me, and we will get back to you on that, Delegate.
Okay, thank you very much for that. Very briefly, and I've spoken with Ms. Successe a couple times about VineLink. We're starting to get a few more people, and I've talked to people at ROAR, which is an organization that works out of the University of Maryland, out of the graduate schools that work as advocates of victims of crime. And they've indicated that they've had people who have been, they've been victims of crime, and people have been released pre-trial. They've been released pre-trial, and no one has gotten notification that they've been released. And I guess this comes back to VineLink a little bit, because I'm wondering whether those connections are actually being made to, obviously people have to sign up for VineLink so that they know when a person is being released, but starting to run into a few more situations where they do sign up and they're not hearing anything. I would them case by case, but I'm wondering if that's something else that's on your radar.
I would encourage anyone that believes that they have an issue with Vine, or it is not appropriately representing their interest and that notification, to please absolutely notify us. If you go to the webpage associated with our Vine system, we will respond to that, and we'd like to hear those cases as we go. So first and foremost, please encourage them to do so, Delegate, and we will get back to them. As you know, we've invested in enhanced Vine. So one of the first things when I got here with the assistance of the Governor's Office of Crime Control and Prevention, we put enhanced Vine in. I believe we're about the 20th state in the country to get that, which is a really enhanced process. Doesn't require a person to go in and register twice and do some other things. So while we had a transition there, I think we're doing a good job with Vine, but if individuals are having individual issue, I would please ask that they come directly to us. And perhaps what we will do, let me go back and revisit the website. And if there's not a clear and broad statement of that, we'll make sure that that is advanced in the website to make sure people know how to get a hold of us.
And I have one last question. Let me get to the one last question, because it's 3 minutes to 3, and I know this is going to be an answer that goes past 3 minutes to 3, but it goes back to the issue of monitoring and pretrial monitoring, and it's one that I'm focusing a little bit more upon in recently. The private home detention. Am I right in thinking that they only get to the private home detention if there are no slots available for home detention available publicly? Or
No,
only slots for home
I don't think
detention
I
are
would assume
private?
that.
Okay, so the only slots for home detention are private ones.
Again, no, Delegate, I wouldn't assume that they are. We have slots in we don't have a minimum max number. We accept people into our program. It's based on assessment. It's based on our assessment process, whether they fit our program. I couldn't speak to how the judiciary makes that decision for home detention, but we have an assessment process. And again, so it's not predicated on whether we don't have a slot or we do not. We assess individuals to see if they fit our program and make a recommendation to the courts involving placement.
So let me take a step back. So a person we're at a bail review. Judge says, I'm going to release you on home detention. And then who runs the program that puts the monitor on that person's leg? I mean, not an artful way of putting it. Who runs that home detention program? So the judge says they're good for home detention. DPSCS, I mean, I guess this is a Baltimore City question, but then I guess it's a local question too. Do they then say, okay, now we're gonna put you on home detention, but if they're out of home detention equipment, does that mean then they go to a private carrier, or then?
So if I may try and tackle this, and hopefully I'll be able to break it down in a manner that is a bit easier to discern. So let's start in Baltimore City, if I may. In Baltimore City, we run the pretrial release services program, and that's what Secretary mentioned in terms of overseen by Director Bob Weisengoff, who does do an excellent job. And we have, knock on wood, have had no issues in terms of capacity. We've seen it grow exponentially over the course of months, from March to October, 165%, and have not had issues in terms of placement on pretrial release supervision that I'm aware of in Baltimore City. So that's completely separate and distinguishable from home detention. Now, our home detention program is specific for individuals incarcerated in our facilities that are typically serving sentences. So if we had an individual who's incarcerated in the Jessup Correctional Institution and they qualify pursuant to the criteria set in statute and in COMAR, then the Commissioner of Correction can move them onto home detention in the community before their expiration of sentence.
And then okay, so let me be a little more precise. So I'm talking more pretrial. I shouldn't have used the word because
that was going to be my
after.
thought.
Okay, I got it. So I'm sorry. So pretrial, so with that, so is that where we're looking at private home monitoring?
That's a great question. Private home detention monitoring agencies, I believe, can monitor both pre-trial and can probably do, I think, some post-sentence as well. And in essence, they are like just private businesses that oversee the supervision of individuals for a fee within the community. And so that recommendation, I believe, is made, and I could be completely mistaken, but it's, I believe, made by the defendant and the defense counsel, and that's ultimately up to the judge to place them under the supervision of a private home detention monitoring agency.
So you're not, you're saying that it's not based on whether there are insufficient monitors in the public system. You're saying that the defense and defense counsel can choose to put a defendant on private home monitoring.
The defense,
because there aren't enough.
In essence, delegate, that's it. I think a fine point on it, within our pretrial release program, we don't do electronic monitoring in our pretrial release program. Our pretrial release program is not dependent on that. It is based on the assessment based on how we wish to manage in the community and assist a person. Should a judge then so desire to take an individual and put them under electronic monitoring on pretrial, they would do so with a private business.
Okay, so you don't do it at all. So
we do not use electronic monitoring with our pretrial program at this time.
With your pretrial program, and all right.
We do with our home detention program.
So you do use it with your home detention, which would be after trial, just not pretrial. Okay, so the question
correct. Post-conviction sentence.
So if they're facing a fee, let's now go to post-conviction. So they're now facing a fee for home monitoring.
Not for our home detention program, Mr. Chairman, not for the run that's.
Right, that's what that said on one of the first screens.
Yes.
Yes, the private home detention monitoring agencies do assess fees for those clients that they electronically monitor. The individuals who are placed under our home detention program they do not currently pay a fee for that supervision.
And it's a pandemic related issue. We're not going to double hit an individual that is in the community, but that fee can exist. We are not collecting that fee at this time, and it's based on work and other factors.
So again, and I'm spinning my wheels, and it's 3:04, so I apologize for coming in late with this question. But the Delegate Moon has asked the question: what if they can't afford the fee? I mean, what I'm trying to get at is, again, now I'm going to switch to post-trial. If somebody, so you have some people who go through the DPSCS program, and then you have some people who are on a private program. And how do they determine whether they're going on a private? How do you determine whether they're going on a private program or on the DPSCS program?
Absolutely.
We do not, Delegate. That is determined by the judge.
So the Commissioner of Correction can place individuals in our system, in our home detention program. A judge would place an individual under the supervision of a private home detention monitoring agency.
Okay. So in other words, if the judge decides they want to put them on home detention and get them out of jail sooner, then the defense counsel, if their client wanted to avoid that fee, would say, I would rather stay in jail as opposed to go out and get the private home detention. I mean, I'm oversimplifying.
Perhaps.
A lot of the local counties also have the statutory authority to have their own home detention program as well.
I got it. So I'll speak more with Delegate Moon. It is 5 minutes after 3. There were a couple of follow-up questions from Delegates Crutchfield and Delegate Williams that I'm going to ask for them to put to the Commissioner in writing. I believe that this has been a fairly thorough briefing, and I do appreciate the Secretary's time. I'll take one more second to say, I did watch the briefing, parts of the briefing yesterday and the day before on sequential. And I think that mental health is a major issue that we're going to need to address more in future legislative sessions. I've been spending a great part of the interim talking about crisis intervention teams and learning more about them and figuring out ways that we can enhance their work. And this committee actually took a strong step in favor of that last year. So I did appreciate your work and the work of Senator Hester and the Lieutenant Governor to bring people together with that yesterday. And with that, a bit of gratuitous talking, I want to thank the committee, thank committee staff, and we are adjourned. Thank you very much.
Thank you all.